Good afternoon. We'll go ahead and start the sessions. Thank you all for coming, and I'd like to welcome you to the first 2023 Gold International COPD educational session. This is our first attempt to bring the GOLD guidelines and put them into clinical context, and there's no better way to do that than join our hands with the COPD Foundation and with patients, because that's really why we do all this, is to advance the awareness and treatment of patients with COPD. So we have 3 sessions today, which Mike Hess will, from the COPD Foundation, will introduce and chair each one. These are geared to be educational sessions for patients. They are for you. If you have a question, you can either type it into an iPad or your iPhone. You can look at your sheet on the back. There's a QR code that you can scan in, or just simply raise your hand. We have people around the room with microphones to take your questions. Really personalize this. It's a small group to make it interactive to get the questions that you want answered. The most important things I have to say are 2. There's food outside if you don't have it. There's bathrooms to the right, and between the food and the bathrooms, there's oxygen. So if you need that, just raise your hand, and we'll be able to provide that for you. The second most important thing I have to say is to thank the people that made this happen. The COPD Foundation and their leadership, GOLD and their leadership, the Temple team, and the people that are helping to produce this session, the Integrity team. So thanks very much. Have a wonderful day. We'll be here for anything you need. Mike?
Thank you very much, Dr. Kreiner. I'd just like to echo his thanks to all of our sponsors, all of the people that made this happen, and of course, all of you in the room with us today, and all of you who are watching online. It's a great honor to be able to moderate this event, the first of its kind here. At the Foundation, we really try to emphasize the patient and caregiver voice in everything that we do. Our founder, John Walsh, was always very, very fond of saying, it's not about us without us. And so we try to amplify those voices and to make sure that we are following the agenda and the needs that all of you find important to us. So we've got a fantastic array of clinicians and patient advocates with us today. And so without further ado, I don't think you need to hear a whole lot more from me. Of course, we'll also be answering questions at the end of the entire session, as mentioned, and we're really looking forward to this being a great resource for all of you, again, for everybody online, and then in the future as people can access the recording of this event. So with that, it is a great honor to introduce probably the most appropriate starters we can come up with, having celebrated Veterans Day this past weekend, observed Veterans Day. We actually have 2 veterans on our panel today to start us off. First off, Dr. Carolyn Smith, a newly minted PhD of Homeland Security and a whole bunch of other stuff, a veteran of the global war on terror in Iraq. Speaking about her experiences there, and then Dr. Courtney Krim, a pulmonologist who I have the great pleasure of working with at the COPD Foundation. So with that, I will first turn it over to Carolyn. Thank you.
Thank you, Mike. Of course, thank you to everybody here. Happy Veterans Day if you're a veteran in the audience. My name is Dr. Carolyn Smith. I am an Iraq veteran, and I am also a newly early-stage COPD patient. Next slide.
Yeah, these are just my disclosures, so we can actually go to the next slide.
So my story is probably a little bit unique. Before I went to the military, I raced a bicycle for 14 years professionally. So I'm very intimately aware of what my lung power was for the majority of my life. I enlisted in the United States Army as a military police officer when I was 29 years old. I gave up my 3rd shot at the Olympics. So I came out of a professional athletic career, went into the military immediately, having very intimate knowledge of my complete body chemistry, and as you could see, these are one of my first attempts at the Olympics. Next slide, please. So on the left, I am less than 1/2 of 1/2 of 1/2 of a percent of women that have been forward deployed in combat. I have over 300 combat patrols as a crew serve machine gunner. So something that maybe not everybody knows about. My COPD really bore about as a burn pit veteran. And if you don't know about burn pit veterans, it's a unique instance where if you're an Iraq or Afghanistan veteran, or like my fellow veteran here, the burn pit veterans are not new to Iraq and Afghanistan. They're also in previous veteran wars as well. But specific to my diagnosis, not only did I inhale several roadside bombs, which led to quite a few debilitating injuries, spinal injuries, and a brain injury and whatnot, but coming from being a professional athlete, my early stage COPD was relatively catastrophic because I've never smoked before. So my diagnosis was a very interesting, pretty crushing experience because it was something that, again, I was intimately familiar with my VO2 max and my ability to have really, really strong, powerful lungs. So coming out of the military with, I'm 100% total and permanent disabled veteran, and if you see me walking around, you probably wouldn't recognize me as somebody with COPD. So my journey here with you is really to talk about the changing demographics of what a COPD patient probably now looks like. It's not just the folks that you see on the commercials, but now it's really about first responders, the military, and those that go around globally to help with catastrophic wildfires and burn pits, et cetera. Next slide, please. Oh, look at me. Look what I have. So when I went into the VA, I didn't have the best experience because I was actually told, well, women aren't really in combat, so why don't you tell us what really happened? And for you ladies in here, this is going to be a funny joke. For you men, it may not be quite as fun. But when I was injured in a roadside bombing incident, my medical file said I was blown up by an IUD. So for you men out here, that means a female contraceptive device. So you can imagine with that kind of care, it was very shocking when I did my first pulmonary functions test that indicated I have the lungs of an 84-year-old. So I transition you back to the first or second slide that showed you that I was a professional athlete and very intimately aware of what my lung capacity was and what it is now. So these are currently how the VA is treating my early stage COPD. And because I'm so new at the stage, I'm very thankful that I have this partnership with the COPD Foundation, and of course, the Gold and Temple, and I'm able here to speak. So I don't have the intimate knowledge of the treatments. That's why I have this lovely veteran friend here of mine that's going to come in here and talk to you about that. But my goal here today with you is that if you are in the stages, whatever stage you are, please be active. Please work with your physicians and your care team and find ways to continue to move outside of your comfort zone, regardless if you are an athlete or not. Work out of your comfort zone. Walk through your COPD diagnosis and find ways to remind yourself that you're not going to be the same person you were before. I'm not going to be that athlete I was before, but your body has what's called muscle memory, and there's parts of you that are going to remember that you were at one time not somebody with COPD. So please push yourself a little bit each day that you're comfortable with and remind yourself that you're still here. You have the opportunity to get up every morning and still be alive, because all of us, if you're a veteran or if you know a veteran, a lot of us have friends like I do that didn't come home from my deployment. So embrace each day, even if you do have this disease as I do, and just remind yourself that you have a powerful opportunity to work within your community to find disruptive technology that will enable you to maybe change how COPD is. So if you're a disruptive technology company, make sure that you involve yourself with the COPD Foundation and other entities to change how COPD works so that somebody in here can help save my life. So I'm going to transfer it now to my... Thank you.
Yeah, I just want to, before I get started, just echo what Dr. Smith indicated. You know, for me, when I met her, albeit initially it was, you know, through a video conference, it was, for me, just impressive, and I really enjoyed meeting a fellow veteran. And although we come from two different generations, and her exposure was burn pits, mine was from burning oil fields when I was deployed during the first Gulf War. So again, having that commonality really was quite impressive and warming to me. I'm supposed to talk about treatments, medicines for treatment, for treating patients with COPD. And although I have these slides, I'm not going to read from the slides. I'm certain many of you have gone through some aspect of, you know, being managed medically with your physicians as it relates to your COPD. But again, the aims of treating patients with COPD is, as you can see from this slide, reducing symptoms and reducing risk. Clearly, I think patients in my clinic definitely want to, you know, address their symptoms. They come in short of breath, or they may change their lifestyle because of shortness of breath. And that they may not complain much because they've decreased their activity level, but there are definitely more things that they could do if they get on proper treatment. Ideally, we would like to affect disease progression, and that's some of the things that's going on as it relates to some of the current research is looking at therapies that could potentially affect disease progression. But currently, our major focus is on preventing and treating the exacerbations, and I'll come back to that as well. But I would be remiss if I didn't talk about that there are non-pharmacological aspects in treating patients with COPD. I'm not going to go through that because my colleagues to my left will be going through some of these aspects in more detail, such as pulmonary rehabilitation, managing exacerbations, so I'm not going to speak to that. But just to remind everyone, which I'm certain you all are aware, that managing COPD is not about just using inhalers or things of that particular nature. There are other aspects that we utilize to manage patients with COPD. And in terms of the pharmacological therapies, I'm certain many of you are quite familiar with these. We break them down into bronchodilators, which can either be short or long-acting bronchodilators. I just have listed some examples of some of the medications that are being used as relates to short-acting or long-acting bronchodilators. This is not an exhaustive list. But again, we have these single bronchodilators, either what we call beta agonists or antimuscarinics. We have combination therapies such as ICS, inhaled corticosteroids, and long-acting beta agonists. And again, you can see some examples listed there on my slide, such as salmeterol, fluticasone, or formoterol and budesonide in terms of ICS LABA combinations. And then in the past few years, to simplify the regimens that patients can use to manage their COPD, we now have we call triple therapy, in which you have 3 medications in a single device. An inhaled corticosteroid, a long-acting muscarinic antagonist, as well as a long-acting beta agonist, all in one device, which hopefully will simplify the treatment for patients with COPD. I don't have to tell you, trying to use 3 different inhalers that work 3 different ways is not ideal or optimal. And so therefore, that we have inhaled medications in which you can have combinations in a single device has definitely advanced the treatment as it relates to particularly patients from the standpoint of simplifying their regimen. And then there are other medications that we use for patients who continue to have exacerbations despite being on maximum inhaled therapies. From the standpoint of the GOLD strategy document, as it relates to how we manage these patients, and as you can see here, their patients are divided from the standpoint of how we would initially approach patients. would be based on their symptoms, and we have two objective scales that we can use, as you can see at the bottom with this MMRC, which is a Medical Research Council scale, or a CAT score, which is a COPD assessment test. And I'll have on the next slide, just an example of what these questionnaires look like. But this is what we use to assess symptoms quantitatively, although we can simply ask patients questions in terms of how far, for example, you can walk before you get short of breath, how many flights of stairs can you climb before you get short of breath, or walking in a mall, what does it take for you to get short of breath? And then we also look at whether they're having exacerbations, and we define these exacerbations as either, particularly from the standpoint of medical management, either moderate exacerbations in which your physician would either use a systemic corticosteroid such as prednisone or antibiotics. And if your exacerbation, that is the worsening of your symptoms, can be managed just with either of those types of medications alone, we call those moderate exacerbations. On the other hand, if you need to be hospitalized for an exacerbation of your COPD, that's what we call severe exacerbations. And therefore, you can see, according to the 2023 GOLD strategy document, if you have only one or no moderate exacerbations, but you are symptomatic, that is an MMRC of at least 2 or a CAT of at least 10, CAT score of at least 10, the suggestion is that the suggestion is that your physician should consider a dual bronchodilator, such as a long-acting beta agonist, a LABA, or a long-acting muscarinic antagonist, or the combination of the two. Whereas if you have fewer symptoms, you can either be used with a short-acting beta agonist, if, again, this is very mild symptoms of shortness of breath, or one of the long-acting bronchodilators. But then if you have more exacerbations or severe exacerbation, then the GOLD strategy document talks about definitely using a combination of long-acting medications, as well as considering the use of adding an inhaled corticosteroid. So again, this is how we basically initiate our therapies based on what the patient's symptoms are and the frequency of their exacerbations. And again, on this slide is just on the left is the MMRC dyspnea scale or shortness of breath scale, and you can see it goes from 0 to 4. And again, on that previous slide, it talked about based on which group you came into, how we would use that. And then likewise, on the right is the COPD assessment test, the CAT assessment, and again, how this ranges up to a score of 40. And again, according to the GOLD strategy document, if you have a score of at least 10, which puts you in that B category, suggesting that you should potentially be considered for a dual bronchodilator. But that's not the end of it, because we will start a subject or patient on treatment, but we need to make certain that the patient is benefiting from it. So again, we would have the patient come back, review to make certain, importantly, that they're using the inhaler correctly, and then to what extent we're having an impact on their symptoms of shortness of breath or exercise intolerance or exacerbations, and then consider either adding or changing their medical regimen, considering pulmonary rehabilitation as an example, again, or if they have difficulties using a particular device, and there may be one that may be easier to use, consider that as well. Always taking into consideration, what your insurance company will support or pay for. And then again, this is just, as I mentioned, from the standpoint of the follow-up. Again, we'll have patients come back, see how they're doing, ensure that they're using their inhaler correctly. Importantly, to have the patient demonstrate every time they come back to the clinic that they're using their inhaler correctly. I can't, comment on the number of times patients have come back, and rather than inhaling from their inhaler, they're blowing into their inhaler. So again, it's important to make certain that the patients are using their inhalers correctly. And then again, based on whether or not they're having frequent exacerbations, this may be a particular pathway that we would take, whereas if they're just having worsening shortness of breath or uncontrolled symptoms of shortness of breath, this is another pathway. But again, the important thing is to individualize the therapy based on the individual patient. Not all patients, can be treated the same way. shortness of breath differs between patients in terms of their perception of it. So again, it's to individualize the treatment. So these are just some of the final points. And again, I think that first bullet point is important. It is about shared decision-making. In the past, back in the Jurassic age when I started medicine, it was the physician talking to the patient, and the patient had very little to say. Clearly now we recognize the importance of the patient's voice, their input. They know what works for them, they know what would not work for them, and therefore it's important to have the patient involved in that decision-making process. What their beliefs are, what devices they may have used previously, what has worked, what hasn't worked. Whether or not they have, for example, arthritis, and therefore using a particular device may not work because they have arthritis in their hand. So these are the sort of things that we have to take into consideration. Education, and again, making certain that the patient is using their inhaler appropriately and correctly are some of the important aspects in that regard. And with that, I'm going to stop to try to keep us on time. But again, thank you for your attention.
So we do actually have a couple of minutes before we jump into the next session. And again, I would like to encourage everybody in the audience online to submit questions. We've had a couple come in that are really great already. And then, of course, you in the audience can submit questions there, or we'll definitely have a Q&A toward the end. But I have a couple of questions that I think might be relevant here, too, particularly with you, Dr. Smith. Being somebody who's relatively new to COPD therapy, were you taught how to use your inhalers? Did you have that education to feel that you were getting an effective dose from some of those inhalers?
That's a great question. I actually didn't know how to use my inhalers, so I went to Google and YouTube because again, I guess they had assumed that I was going to go off and figure this out by myself, which is why I actually found this. I personally reached out to the COPD Foundation when I got this diagnosis, and that's where I learned most about my disease, not from the VA. I actually reached out to the foundation, and that's how I learned about it. So I know more now from the VA than I did at that time from my provider. So.
Great, thank you. Also, it came in through the chat that somebody pointed out that I may have forgotten to introduce Dr. Courtney Krim, so I first apologize for that. I thought I did, but in any event, this second question also came in through the chat, which kind of relates to that whole idea of shared decision-making. So, Dr. Krim, do you have suggestions about how patients can develop a team approach with their pulmonologist?
I can tell you what I do. One is that I definitely, when I'm seeing a patient, make certain that they have all of their questions answered. And oftentimes if they come with their spouse, I will make certain that I direct part of that to the spouse to get the input, because oftentimes the spouse will speak up more than the patient. But again, is to inquire about things in terms of what their lifestyle is like, what kind of things can they do around the home, what their dexterity is like, and again, to really have that in-depth discussion from the standpoint of exactly, for example, what does it take to get you short of breath? What can't you do that you would like to do? Have you altered your lifestyle? An example that I give is a person who may have been an avid golfer who initially was, carrying their clubs the full 18 holes. Then they come back, or then they mention how they're still playing 18 holes of golf, but now they use a cart to move their clubs. Or they're still playing 18 holes, but now they're riding in a cart. As far as they're concerned, they're still playing 18 holes of golf, but they've altered their lifestyle in order to do that. So these are the types of questions that I try to generate to get a sense of, you may have slowed down, so to speak, and if it's because of your shortness of breath, and then what can we do to address that? So that I definitely try to get them to actively participate in that discussion to get an idea of what they are able to do, what their limitations are, to then get feedback from the standpoint of what we can do to address it.
So the follow-up to that was, how does a patient initiate that conversation with a pulmonologist who isn't? Courtney Krim, how do you promote that kind of self-efficacy or proactivity?
As I kind of alluded to, oftentimes, with that initial visit, they're coming with their spouse. And usually the spouse is more vocal than the patient. So getting the spouse involved in that conversation will then bring out, the patient, I'll say co-signing what was, being discussed. But again, it's, those types of things, finding out who is the patient's advocate, because all patients need to have an advocate, because otherwise physicians will, blow over certain things unless someone is speaking up for the patient. And it could be a sibling, it could be a relative, it could be a friend, but all patients need to have an advocate. And I've seen that even my own family. Just briefly, my sister was supposedly diagnosed with COPD, placed on an inhaler, and then talking to the physician, and talking to her, she's never had pulmonary function studies. But yet she was placed on the triple therapy. So again, I had to become her advocate to push her physician to consider things like pulmonary function studies rather than telling the physician, because you know how egocentric physicians can be, rather than telling the physician about maybe these are things that he should consider.
And I wanted to add another thing. I'm single, and there's an interesting thing that happens when you're single or you're dating and you don't have a spouse or somebody that goes to you with your physician. There's really uncomfortable conversations when you're what's the technical term? Trying to procreate? That changes when you have early COPD and you're a younger person. Think about all the premature children that have underdeveloped lungs and are going to have issues when they get a little bit older. There is a whole subset of folks that are first responders, Team Rubicon, people that respond to catastrophic wildfires, tsunamis, floods, fires, and not everybody is going to have a husband, wife, fill in the blank. So if you're that kind of person like I am, you really have to be, nobody's coming to save you. You have to be your own advocate. You have to have these very uncomfortable conversations of what interrupts your daily life, because if your doctor doesn't know these things, then it's going to be the wrong avenue of approach to help you out. So don't be afraid to have these very uncomfortable dialogue with your doctor, and let them know, hey, also these things, your dating life and the things you do inside your dating life, are affected as well, because there's going to be things that maybe they can help you out with, so you can have some sort of normal, whatever that term is supposed to actually be, but don't be afraid to have those conversations if you don't have somebody else in the room with you as your partner, spouse, husband, wife, whatever it is. Be your own advocate.
All right. Carolyn Smith and Courtney Krim. We'll be taking questions at the end of the overall session, some additional questions here, so hold that thought. Thank you very much. That's the end of our first patient session. Next up is going to be something that is slightly different because one of our patient advocate who had hoped to be here is actually having a flare-up right now, or recovering from one. So next up, we're going to have Caroline Gaynor, one of our COPD Foundation advocacy captains, who will be actually joining us via Zoom. And we have Dr. Wishia Wejida from the Royal College of London. Imperial College. I was so close. So I will hand it now over to Caroline. And you had some slides, correct?
Yes.
Okay.
I should be able to advance them.
I'm sorry?
They haven't fixed up, I think, so I can advance them myself.
Okay, I can handle that from here. So go ahead and tell us a little bit about your story.
Okay. I was diagnosed with COPD when I was 69 years old, which was 10 years ago. I was diagnosed when I was hospitalized for a pneumothorax, or in other words, a collapsed lung. And I ended up with two more pneumothoraxes, and also with pneumonia combined with the two lung collapses. Then I went for 4 years until last fall before I had another exacerbation that I had to be hospitalized with. I am very, very prone to upper respiratory infections, so I've had some of those along the way, but they were moderate, as we just now heard. I had a very hard time telling whether or not I was sick. I didn't know when I needed to go to the doctor or when I needed to just take it easy for a little while. And my saving grace has been the COPD Foundation's care plan or action plan. The top part of the plan is important, I think. Well, it's important to do this with your doctor if that's possible. It isn't always possible, so if it isn't possible, I think it's still uh, a very good thing to do this on your own. You can benefit from doing this part without your doctor. So you're going to go through and you're going to say whether or not you can do each one of these activities, to what extent can you do them, how much problem do you have doing these, and it's good to review this every year. Then the next part of the action plan is a normal day. That's a green day. That's a day that I feel like doing the most that I can do. And so I assess this every morning as I'm taking my medicine and doing my inhalers. I assess my condition. Am I okay? Am I having a green day or am I not? The yellow day is a day that things are not going quite like they should. I might be a little short of breath. I might have more cough or more phlegm than usual. I might not have slept well the night before. And this is a day that I'm going to consider whether or not I'm actually coming down with something, or is this going to pass. So on that day, I will probably take it easy. I may or may not start, depending upon the symptoms that I have, I may or may not start on an over-the-counter drug that I have. For instance, like maybe I'm going to start Mucinex because I think maybe my head might be congested. My head's a little bit sore. I have a little bit of a sinus pressure headache, and I'm going to take it easy. And then if I don't get worse, then that's fine. We've taken care of that. But sometimes we have one of these red days, and I had one of those red days this week. I woke up. Actually, this is probably a little more sharing than some of you would like, but I have to blow my nose every morning because I'm always stuffed up. And when I did, both of my ears popped. And I knew, that might not be good, because it seems as though whenever my ears pop, then I'm headed for an upper respiratory infection. So about 5 o'clock, I felt really tired, and I decided to lie down. And when I got up, I was woo. I could not walk straight at all. I was just bouncing off the walls and going down the hallway to the bathroom. And so I knew this is something we're going to have to take care of the next day. So I called my doctor and I started on an antibiotic and Mucinex. He asked me, he said, which antibiotic do you have on hand right now? And I told him, and he said, well, that's good. That's the one I would have prescribed for you. So go ahead and start taking it. This actually has been the reason, in my opinion, that I have not been in the hospital except for one time in the past 6 years. I would advise everyone to have some sort of plan, and this to me is the best one possible to have in order to avoid an exacerbation. So I think this is about what I have to say.
All right, we will hand that over to our clinical expert.
Mike, do you mind if I use the...
Oh, not at all.
Because
Not at all.
I just cannot see the slides over the table, if that's... I think Carolyn's got the same problem as I have, so... I think we all may need this. Okay. So, first of all, thank you very much to the COPD Foundation and Temple and Gold for the wonderful invitation. This is the first time I've been to your meeting. I've been to the main one, but not to this one, and I'm really delighted. I am from the UK, and we have a lot of COPD. My main interest all my life has been COPD exacerbations, and how I got interested in it was that we were doing a study of inhaled steroids back in the mid-90s, and we noticed that as we were taking patients off inhaled steroids, they were getting worse, and that prompted really a lifelong time of research. This is why I'm particularly happy to be here. In fact, Caroline's really done my talk for me. She's told us all how important it is to recognize symptoms and their severity. It's so important that my ex-colleague, who sadly died a few months ago, one of the last conversations I had with him, I said, well, what do you think of all the new definitions? He said, it doesn't matter what definition we have. It is up to the patient to tell us they have an exacerbation. Otherwise, the field won't move forward. And this is exactly what Caroline has done with her action plan, which is tremendous. What are the main symptoms of exacerbations? I've been asked to go through some of the information: shortness of breath, increased sputum volume, sputum purulence, and then there's other symptoms. Colds, half of colds will become exacerbations. That's the statistics. So a cold is an important marker that you may go on and get infections. And my sort of wish is that in the future, when we have antiviral drugs, that at the start of a cold, you'll be able to take some medication that hopefully we all wish will prevent the exacerbation. Fever, in fact, Caroline had a low-grade fever, if you remember. You don't get, in most exacerbations, unless you've got flu or COVID, and in that case, you have pneumonia. Now, she also said something very interesting. She said some exacerbations happen quickly, and this is, in fact, the time course of shortness of breath. It's a quick exacerbation. Some can take more time to develop. And in fact, we want treatment to start as soon as possible. The earlier you start treatment, the better. The other thing is that you can see that the exacerbation doesn't quite go back to normal. And we know that at 5 weeks, a quarter of exacerbations will not recover. Now, this is a very important statistic, because if an exacerbation doesn't recover, lung function doesn't recover, and we can get disease progression. So it is very important, if your exacerbation hasn't recovered, to go back and see your healthcare professionals or your contact, and you may need some more treatment. So what about exacerbation risks? This was the first paper that we wrote after we got interested in it, and I always like showing it. It's 'cause it's 25 years old, and we showed then that you were at exacerbation risk if you had exacerbations in the previous year, and also bronchitis. Now, this is interesting, and if you look at the development of early COPD, cough and sputum are often the earliest symptoms, and they are often occur in the winter months, because you get a cold, and that causes cough and sputum, which then can persist. So that's a marker that there's going to be problems downstream. Now, whether you have mild COPD, early COPD, or more advanced, the exacerbation tends to be pretty similar. So you get exactly the same symptoms as I showed you. And this is data from the famous ECLIPSE study. I always show it, and this is to remind you that all stages of COPD will get exacerbations, and even in gold stage 2, so that is the moderate patients. We haven't got gold 1 here because they weren't collected in ECLIPSE. 7% of these patients have already been admitted to hospital. So exacerbations are important across the disease severity. And lung function is also a risk factor. As I said, they cause disease progression. This is again back to Gavin Donaldson's work with us, and he showed that frequent exacerbators, in fact, decline faster, and we attributed about a quarter of the lung function drop to the effect of exacerbations. The other thing is unreported events, and one thing that surprised us, so we did a very simple diary card, which wasn't then digitalized at the time, but we noticed there were a lot of symptom complexes. When we asked patients, what did you do? Oh, it was Christmas, it was the weekend, I just waited it out. Well, Gavin then did another paper where he showed that unreported exacerbations can also non-recover and deal and give you disease progression. So it's very important to recognize exacerbations. And this is data that we showed that if you have more unreported exacerbations, then in fact the quality of life is worse. So unreported exacerbations, and in the same way, patients who end up in hospital are very often those who have more unreported exacerbations. So perception of exacerbations is so important. And again, Caroline's action plan is brilliant. Or a simple diary, or if you don't have access to an action plan, is a simple diary will work to monitor the symptoms. So the other thing I said, early treatment. And what this graph, this is also from our group, shows you that the longer the delay, the longer the exacerbation will last. So symptom recovery, if you delay treatment, it will then take you longer to get better. At the moment, my group is studying what happens during recovery. We know very little about it. We tried to do a study of giving a second antibiotic. That didn't work. So it's a very interesting period, is exacerbation recovery, but it is crucial in maintaining lung health. So the other issue is, what other impacts do exacerbations have? And we know that if you have a severe exacerbation particularly, you're more likely to have an added ischemic event. And this is why early intervention is important. I also believe early intervention, in fact, reduces the risk of pneumonia. This, in fact, is data from a study that was called Summit. And this shows that if you are hospitalized on the right-hand side, your chances of an ischemic event in the first 30 days are very high. So you need blood tests. Your doctors need to keep an eye on this, in fact, because severe infection can certainly, a severe inflammatory process can lead to ischemic events. I'm going to finish off with a few slides. Oh, in fact, I can't see. I'm going to have to go back, actually, Mike. There's the light's right in my face. But I'm going to have to, can't see actually, that's better. I'm sorry about this, the light went directly into my eye. So what are the indications for coming into hospital? Now, Caroline has beautifully, in fact, told us already about things, severe symptoms, if your fingers go blue. Failure, a few other things, failure of an exacerbation to respond. And the other thing is, if you have other comorbidities, the impact of that exacerbation will be much greater. So it's really important to understand that. How do we manage exacerbations? Well, Caroline showed us, and I won't go into it in detail, rescue treatment, steroids, antibiotics if your sputum goes green. You don't need antibiotics unless your sputum goes green or or changes in volume. And then if one is more ill in hospital, that will progress. Now, I'm going to finish up with follow-up. I don't think it's done well enough. If you have an exacerbation where you are hospitalized, you do need follow-up. A bad community exacerbation must be follow-up. Your treatment may need to be changed. If you have one severe exacerbation, you are at risk of more exacerbations. So Gold has a very nice table about recommendations for follow-up, which we recommend. So just to finish off, every exacerbation counts. It's a revolving circle. That's the impression I got from Caroline's presentation today, and I specifically put in this slide. You're stable, you become susceptible through infections, and you get an exacerbation. You're slow to recovery, and here we go again. And all these things in the middle, and not only disease progression, mortality, cardiac events, but also anxiety and depression and psychological factors. Every exacerbation counts. Thank you. I'm sorry about having to change, but I suddenly couldn't see the slides.
Before we tag everybody out, there are a couple of questions in the chat that I think really directly impact this slide and a couple of the other slides that you mentioned about the potential impact of unreported exacerbations. One person says, how can we teach health professionals to encourage patients to monitor their own situations and reduce the, quote, tough your way through it mindset? But then the counterpoint to that, which I think is also quite valid, we hide/accept/don't report exacerbations because we're tired, we're frustrated with being sick, et cetera. If someone is treating their exacerbation at home, do we need to let the doctor know, even though I don't want 911, 999, or hospitalization? So how do we then, again, I guess it kind of goes back to that team approach. How do you work collectively together to make sure that all exacerbations are counted and treated appropriately without going against the patient's wishes?
Shall I start off, and maybe Caroline wants to come in? Well, first of all, I think education is very important. Understanding the symptoms, understanding how they evolve. As I said, half come from, half of exacerbations, in fact, follow colds. That's very important. It may be even higher. And then I think if you're not sure whether to take your symptoms, do give the physician, or in the UK, we have special units that will deal with this. Contact your healthcare professionals for advice. That is my recommendation. And I think it's to understand not all exacerbations will, for instance, need steroids. And one needs to, as you go along, to understand when the steroids will be needed, when you have a more severe exacerbation affecting your activities of daily living. So it is education, and it's your interaction here with the healthcare professionals, I think, is very important.
Great. All right, thank you very much. So our next set, and then we're going to have a little bit of a break. We're going to be talking about pulmonary rehabilitation, monitor exercise programs to help people live their best lives and stay active, as we've heard from our first set of speakers. And for that, we are going to hear from another one of our COPD Foundation advocacy captains, Phyllis DiLorenzo, and we're going to hear from pulmonary rehab expert Dr. Carly Rochester from the Yale University School of Medicine. So we'll start off, we'll hand it over to you, Phyllis.
Thank you, Mike. I'd like to thank everyone for coming here today to listen to the patients and doctors. It's very important. I have had COPD for 8 years. I'm stage 2 moderate, and I've been stable for the last 5 years. I have not had, thank you, I have not had any exacerbations or hospitalizations in 5 years. I've had what I call mild flares, colds, different things, sinus infections, and they were treated at home, and only one of those required steroids. Now, when I was diagnosed not in the usual way. My diagnosis was by a primary care physician subsequent to an episode of pneumonia by X-ray. At that time, I knew nothing of COPD, what the proper diagnosis was, or how it was treated. So when I was told I had emphysema, I said to myself, oh my grandmother had that. And she went from being a very active woman to someone who never left the couch, stopped walking her dog, and just lingered. And I said, that's not what I want from myself. What do I do? And I became very depressed because I was an active person. I was always running somewhere. I lived in Manhattan at the time and worked in Manhattan, and I was always running to the train, to a bus, always on the run. And I hiked. And I said, now what happens? I can't breathe. I can't walk to the bathroom without being short of breath. Well, my primary care physician said, well, you have emphysema. Of course you're going to be short of breath. Finally, after 3 more exacerbations and 4 days hospitalized on a BiPAP, it was strongly recommended that I not only follow up with my primary care, but that I see a pulmonologist ASAP for a spirometry test. I had no idea what a spirometry test was. No clue whatsoever. And when I saw the pulmonologist and he went to put a clip on my nose, I said, oh my God, what is this? But yeah, I got through that, and I'm so glad that I did, because right then and there, the pulmonologist prescribed 2 maintenance inhalers, which I had never heard of maintenance inhalers. All I had was a rescue inhaler, and boy, oh boy, a nebulizer. Oh, I love my nebulizer. It was wonderful, but it didn't keep me stable. What kept me stable were the maintenance inhalers. But, yes, I was having less shortness of breath, but I wasn't feeling any more energy. I was still depressed. I couldn't do the things that I was doing before, and I really felt like my life had been stolen from me. So I went to the doctor and I said, you know, I think I'm depressed. And he said, are you lonely? And I said, well, you know, 25 years in mental health, I think I know when I have depression. So I was given antidepressants, and as antidepressants are, sometimes they work for people, sometimes they don't, and I was sort of in between there and languishing, still saying to myself, what do I do? So I finally went online and found support groups, and I found the COPD Foundation, and I started talking to patients, and they were telling me about pulmonary rehab, and I said, pulmonary rehab, what is that? And they said, it's a program of exercise and information about COPD that will change your life and will improve things. And I said, really? Well, I can't believe that. And I really didn't. Until finally, I got a call from someone in the foundation and said, Phyllis, would you be interested in attending pulmonary rehab? And I said, I don't know. I can't exercise now. I can't walked very far, and they said, we know, that's why we're asking about pulmonary rehab. And I said, okay, I'll give it a try. And I did a 24-week program, and it was life-changing. I live in an area in Jersey City surrounded by hills. There is a beautiful park with 26 acres that I had never explored except for just near the entrance because of the hills. Attending pulmonary rehab got me to walk up those hills, got me to explore that park. I am now walking that park and taking photographs of the wildlife that I find, the birds, whatever there is there. We have egrets, we have hawks, we have all sorts of wonderful wildlife. And it's a new hobby for me. It's something that I never did before. And it's given me something that is in my neighborhood that I can do. The walk is challenging, and it's in nature, which is what I loved. It's sort of given me that back. I can no longer hike, but I can go to my local park, and I can be with nature there. Pulmonary rehab should be, I believe, offered to everyone the moment they are diagnosed. It is not only the exercise, it's not only building up your muscles, it's giving you information about how to deal with your COPD when you're not feeling well, when you're short of breath, how to recover your breath with breathing techniques. And the better pulmonary rehab programs also have social sessions, meetings. And these are crucial for COPD patients. To be able to socialize with other COPD patients, to know that you're not alone, that there are other people going through the same things, people that you can learn from, and you know that they've been there, they've walked in your shoes. And that is what is the life changer about pulmonary rehab. Once you meet the people who are doing it, you start to do it, you grow confidence, and you begin to say, you know what, I have COPD, and that's not so great, but I can live a life with it, and I'm going to live the best life I can. And that's what I've been doing. I've been going around, traveling, speaking for the COPD Foundation, the American Lung Association, the American Thoracic Society. And I travel now. I travel more now than when I was working. I visit my family. I'm here going this place to a meeting, and it's been a new journey for me, and it's very surprising. It's something that I never expected a disease would open up a new journey for me. And this is what I hope for all COPD patients, not necessarily the path of advocacy, but my sincere hope is that they find something that tells them, it's okay, I can live with this, and I'm going to live my best life. So all I want to say is pulmonary rehab needs to be available to COPD patients right away, as soon as they're diagnosed, please. It's very important. And thank you for listening to me.
And now we're going to hear about what to expect from pulmonary rehab, and based on a couple of questions in the chat, how best to access it.
Great. Well, thank you, Phyllis. Thank you to all the other speakers. This has been a really wonderful and enlightening afternoon. My name's Carolyn Rochester. People know me as Carly, and I'm delighted to be here. I'd like to thank the conference and session organizers for inviting me to join you this afternoon to talk about pulmonary rehabilitation. There's absolutely nothing that I could say that could champion pulmonary rehabilitation better than Phyllis DiLorenzo's compelling and thoughtful words, which I think just beautifully articulated what pulmonary rehabilitation is all about. I will, in the next several minutes, highlight some things about pulmonary rehabilitation from a healthcare professional's perspective, and also address some of the questions that I was asked to address in the title of this talk. And also, I just want to emphasize that pulmonary rehabilitation is meant to be a collaborative process between healthcare professionals and people affected by chronic respiratory diseases, COPD and others. You know, some questions have come up earlier around the issue of, well, how do we engage with our healthcare professional? This is one avenue that really affords an opportunity to do that. So with that, as an introduction, these are my disclosures. So I was asked to touch on the definition, the key components and goals of pulmonary rehab, address why should people do pulmonary rehab, so I'll talk about the rationale for it, patient candidacy, address some aspects of key expected outcomes, how long does pulmonary rehab benefits last, what about maintenance pulmonary rehabilitation, and I'll touch on telerehabilitation and just close with a little bit about existing barriers to pulmonary rehabilitation. So many of you may have been through pulmonary rehabilitation, may know this already, but the official definition of pulmonary rehabilitation, just to bring us all to the same page, is that it's a comprehensive intervention based on a thorough patient assessment followed by patient-tailored therapies, which include but are not limited to exercise training, education, and behavior change designed to improve the physical and psychological condition of people with chronic respiratory disease and to promote the long-term adherence to health-enhancing behaviors, such as, for example, physical activity, recognition, and early treatment of exacerbations. So the goals of pulmonary rehab are to reduce and minimize the symptom burden, to maximize exercise performance and promote autonomy, increase participation in everyday activities, enhance health-related quality of life, and affect long-term health-enhancing behavior. So let's start with why pulmonary rehabilitation. What's the rationale? Well, in fact, people have symptoms, notably amongst which include shortness of breath. Now, shortness of breath comes from many causes. In addition to the structural and functional changes going on in the lungs themselves, which together lead to breathing limitation, low oxygen levels, high carbon dioxide levels, and increased demand on the breathing. In addition to those problems leading to shortness of breath, which we know as dyspnea as a medical term, people who have COPD and other lung diseases have lots of systemic manifestations and comorbidities, notable amongst which are things such as anemia, orthopedic problems, cardiovascular issues, and one that I want to highlight today, skeletal muscle dysfunction, meaning dysfunction of the limbs of, the lower limbs and upper limbs, the extremities. And it's really the lung problems themselves together with these systemic manifestations and comorbidities that collectively lead to exercise intolerance, shortness of breath, which in turn contribute to people's anxiety, fear, isolation, loneliness, depression, decreased quality of life. All of that feeds back into, if you're short of breath and you don't feel good, decreased participation in daily activities, low physical activity levels, which in turn leads to deconditioning, frailty, functional disability, and feeds back to worsen the comorbidities, and it becomes a vicious circle. So pulmonary rehabilitation actually doesn't address, it's important to note, doesn't address or change the structural and functional changes in your lungs themselves. That's what bronchodilators are for. That's what supplemental oxygen, non-invasive ventilation, and other strategies are for. But pulmonary rehabilitation addresses the systemic manifestations of the disease, including the skeletal muscle dysfunction. And I want to just highlight that a little bit more because it's so essential to the rationale for pulmonary rehab. So when people are inactive and don't do things, as is logical to do if you feel short of breath when you do things, people's muscles become deconditioned. And in addition to deconditioning, there are many other mechanisms as well. But just to highlight this, what happens as a consequence of inactivity and multiple other concurrent mechanisms, systemic inflammation, for some people hypoxemia and other things, you get structural and functional changes actually in your muscle fibers. You have a decrease in the enzymes or the proteins in your muscles that enable you to actually sustain endurance when you exercise. You get decreased blood contacts to your muscle fibers. You get a change in the energy metabolism that your muscle fibers can do. And what that does is do a couple of key things. One is it changes your metabolism so that you produce something called lactic acid earlier on with lower levels of activity, which sends a signal to your brain to breathe harder. And the last thing you need to do is to breathe harder already, right? In addition, inactivity and deconditioning leads to reduction in muscle mass, decreased strength, and decreased endurance. So these things collectively, and especially if you're working harder to breathe and you have lactic acidosis during lower amounts of exercise, then you're going to hyperinflate. You're going to progressively inflate your lungs to the point where your breathing muscles can't work as well for you. And all of those things together lead to your exercise ability being reduced. So pulmonary rehabilitation, through its exercise training, stabilizes or actually reverses a lot of these structural, functional, and metabolic issues in your muscle such that you can do more activity with less shortness of breath. And in fact, training the limb muscles, albeit quite sort of paradoxical in its sort of upfront ideology, is if you train the limb muscles, you help the breathing despite no change in your lung function itself. Because you improve your aerobic fitness, you can exercise to a higher level, you can utilize oxygen better, and you can get to a higher amount of activity before your body converts to that metabolism where it produces excess acid. And then in turn, when you're exercising, you have less hyperinflation of your lungs, your breathing muscles can work better, your gas exchange may be improved, and you're going to be able to do more with less shortness of breath. So that's a scientific rationale for the exercise training part. Now, in addition, we all know when we go to our healthcare provider, we get, 15, 20, 30 max minutes with a healthcare provider. And that's really not enough time to deal with all the things that go on to living with chronic respiratory impairment and other comorbidities. So we have complex treatment regimens to deal with, sometimes conflicting recommendations from lots of different providers, and we just don't have enough time to deal with that in the routine appointment setting. So pulmonary rehab provides the opportunity for people to work collaboratively with a team of healthcare professionals over an extended period of time, and we have opportunities to gain knowledge that foster coping and disease management, as Phyllis was talking about. And there's lots of typical education topics that you can see on this slide, and it varies from program to program. But the idea is you learn about your condition, you learn how to manage your condition, you learn how to recognize exacerbations, you learn what to do to actually collaboratively manage your condition, breathing techniques and pacing and energy conservation techniques that help you do more in collaboration with your healthcare professional. Yeah, I think we started a few minutes late, so I'm going to keep moving here. So who's a candidate? People who are symptomatic with dyspnea, anxiety, fatigue, shortness of breath, and or who have physical and functional limitations, difficulty with activities of daily living, and suboptimal disease management, and all of that despite their optimized medical pharmacologic management and who have impaired quality of life. There's very few actual outright contraindications to pulmonary rehab. The essential components, as we said before, are exercise training, which is usually supervised, structured, and progressive aerobic and strength training of the lower and upper limbs. We do a variety of testing, simple testing, walk tests, for example, simple types of walk tests, or sometimes dowel lifts for the arms, and various questionnaires to understand what your starting point is, and we repeat those at the end of the program. The patient education program that I mentioned, and programs themselves have quality assurance parts built into it to make sure their programs are as effective as they should be. Most programs in the United States meet 2 to 3 times a week for 8 to 12 weeks, for at least the outpatient programs. You can expect from pulmonary rehabilitation to improve your exercise capacity, to reduce your shortness of breath and leg fatigue, to improve your ability to do activities of daily living, reduce anxiety and depression, improve health-related quality of life, improve your knowledge and your collaborative self-management skills, and indeed reduce hospitalizations and unscheduled health care visits. You may, if you particularly participate continually after pulmonary rehab, increase your daily physical activity levels, and I'll mention improved survival in a second. Now, I'm going to just skip over data for sake of time, but just want to highlight to you, the only reason I put any data slides in here at all is to emphasize, A, there's a ton of data showing that this works on multiple fronts, for exercise capacity, for dyspnea, for quality of life, and improved emotion function, just showing you there's many, many trials. They're all very consistent in their findings. I do want to highlight this one piece of data, which is that a recent study, retrospective analysis of a large cohort of Medicare beneficiaries from the United States were found to have a reduction in mortality if they participated in pulmonary rehabilitation within 90 days of discharge after hospitalization for COPD exacerbation. This is really important, and another reason to ask your healthcare professionals to refer you if you haven't been. The benefits of pulmonary rehab typically last 8 to 12 months. We know that repeat courses are beneficial, but unfortunately insurance payers, including CMS, often limit to a lifetime number of 72 sessions, with exception if a person needs lung transplantation. Maintenance is important. We all know that continued exercise and physical activity after program completion is essential to main benefits over time. If one becomes a couch potato after participating in pulmonary rehab, your benefits will wane. That stands to reason. Some programs do offer maintenance programs as part of their sessions. A lot of them are self-pay. Unfortunately, research regarding maintenance pulmonary rehab after an initial course of pulmonary rehab has not consistently shown benefit to the point where we're able to actually formally recommend it yet. But I would say absence of evidence is not evidence of absence. That is to say, more work is needed, and we all agree that maintenance exercise and maintenance to the underlying sort of disease recognition and management is very important. Telerehabilitation is an emerging option for pulmonary rehab. There are various models that have been used, everything from simple handheld apps on the phone to video conferencing to hub and spoke models. So far, what we know is that as compared to center-based pulmonary rehab, there are fairly comparable gains in 6-minute walk test or as a measure of exercise capacity, shortness of breath, and quality of life. Participants like pulmonary rehab, telerehab, and are more likely to complete it without any adverse effects. But there are some caveats, and I just put these out there, and we won't wade through them in great detail, but telerehab is meant to improve access to pulmonary rehab for people who might otherwise not be able to access it, number one. Number two, it isn't suitable for all people. There are a lot of reasons why not. There are still some legal and privacy concerns. It's not yet widely funded. There's no clear infrastructure for it. So telerehabilitation is something that is really on the horizon, and it's already in use in many cases investigatively, although we did have an emergence of it much more clinically routinely in the COVID pandemic. And lastly, there are some barriers to pulmonary rehab that we just need to acknowledge. Fewer than 5% of people who have COPD actually have received pulmonary rehabilitation. That's really a terrible number, right? And it's lower than that after COPD exacerbation and hospitalization. It's on the order of 2 to 3%. Right, so there's a lot of patient-related barriers. People have never heard of it. Sometimes people never heard of even the COPD or spirometry. People are often not told about pulmonary rehabilitation, or they have transportation difficulties, or there's no pulmonary rehab program in the area, geographic barriers, socioeconomic barriers, even, sadly to say, racial barriers in terms of access to pulmonary rehabilitation. And all of these things we really need to address, key amongst which are low funding and reimbursement for pulmonary rehabilitation on the part of our health systems, and this is something we need advocacy for. So we just recently published this clinical practice guideline from the American Thoracic Society for Pulmonary Rehabilitation. I won't walk through it except to say that we do recommend pulmonary rehab for people with stable COPD and for those after a hospitalization for COPD exacerbation, and we recommend consideration of telerehabilitation for some patients patients to increase access, not in place of center-based, but in addition to expand access for some people. And there's a lot more work to be done in that area. So this is Phyllis's and my take-home message. We worked on this together. Number 1, pulmonary rehabilitation works. It's effective. Number 2, it's so important. 3, don't miss it. 4, advocate for it. And thank you very much. There's a couple of resources here on your slide.
Wow. I know we've thrown a lot of information at you in the last hour or so. This is a time that is designated for a break, and I absolutely encourage everybody to visit the vendor hall. We can't do this without them. Take care of any other needs you might have, but I also want to make sure that we're offering some question and answer period for the folks in the room here. I know we had at least one question earlier. I'm sure some other people have had that. For those people online, we do want to get to as many of these questions as we can. Can't guarantee we're going to get to all of them today, but I think we can certainly have some kind of mechanism to make sure that they get answered at some point. So.
Thank you. I have one comment and one question. So first, great presentation for each and every one of you. 5 stars, one for each of you, and Mike, I give you kudos on putting together such a great panel. My comment is that, Phyllis, you alluded to it, and I know, you talked about the fact that you love your nebulizer, and like everybody was so excited when triple therapy came about, right? I can. Everybody was thrilled when triple therapy came about, except nobody really talks about, the mechanism of taking the meds. And what I worry about and what I see with a lot of patients is that you now have all 3 in one, and if you miss it, you missed all 3. So for a lot of patients, we find that if we back them off and they get them back on the nebulizer, all of a sudden they're like, wow, that's great. And we see great results with that. My question is, as part of the asthma initiative, the global asthma initiative, they're using a lot of times short-acting bronchodilators with a steroid combo that is taken as needed. So every time you'd be taking your albuterol, you're also getting a corticosteroid. Do you think that that would be beneficial to COPD patients as well as asthma patients, doctors?
I think, before we can say that, as they have done studies in patients with asthma, there are no studies of that comparability in patients with COPD. So before I think we can even advocate something like that, we would need to do the clinical trials to see exactly what the effects are. The one thing that I would say about asthma, which I still have a question about, is one of the things that we had always been concerned about with asthma was this whole issue of airway remodeling in the context that taking a maintenance medication on a regular basis, potentially can have an impact on asthma remodeling. Clearly, a short-acting beta agonist and a steroid alleviates the symptoms, minimizes the exacerbations. To me, what is unclear is to what extent it has an impact on airway remodeling. So, but to get back to your question, I think before we can make that type of recommendation in patients with COPD would be to do the clinical trials. And I don't know if any of my colleagues wish to comment further.
I think Visha and I both had the same thought, which was that there's also a signal for an increased pneumonia risk with regular use of inhaled corticosteroids that's not inconsequential, and it's something that we're concerned about. We acknowledge the need for inhaled corticosteroids in people with COPD where it's been shown to be effective to reduce exacerbations or to manage exacerbations, but it's a concern for just sort of blanket doing it for everyone. And the airways inflammation is different in COPD versus asthma also, so.
And maybe, sorry. Oh, yeah. Maybe I can actually add, what's interesting about COPD is that you don't need a lot of inhaled corticosteroid to prevent exacerbations. And that has been shown in the ethos study where 2 doses were used. They were identical. There were many years ago, there were the low-dose adverse studies. I'm right, Courtney, were used only 250 BD, wasn't it? And that they were as good. I remember Tony Anzueta was the author on one, Mark Dransfield on the other. They showed they were as good as in the UK when we were using much higher doses. So I would really be very careful. The new triple therapies have much lower effective doses of ICS, and they're enough to prevent exacerbations. I think there are some interesting questions. What can you do instead of oral corticosteroids? But maybe that's for next year, not this year.
Yeah, just one last comment. Clearly it's something that needs to be studied because, for example, and I think we all recognize the potential pitfalls of, steroids in certain patients as it relates to the risk of pneumonia in some patients. The other thing that we do know from studies that have been published thus far is compared with a non-steroid regimen, steroid regimens, there are studies that shown it has an effect on the rate of decline of FEV1, and there are studies that suggest that it has a beneficial effect compared to non-steroid regimens on even mortality. So again, it's something that needs to be explored, but again, that's totally different than taking it PRN. These were studies that were people taking on a regular basis.
Any other questions from the room? Oh, we got a couple people. Okay, somebody in the back.
My name's Mike, and if I understood the presentation, our current medical system only permits 72 pulmonary rehabilitation sessions. Is that correct?
Yes, sir.
And is it over a year, or is that lifetime?
Lifetime.
Thank you.
That's why we need advocacy.
Well, there shouldn't be a limit.
There's a question up
No,
here.
there really shouldn't be a limit because the repeat courses are, first of all, in order, it's a lifelong disease that one is living with, and it stands to reason that short-term intervention wouldn't last a full lifetime, and yet we do know that repeat courses are effective. It's a cost and availability issue at present as to why we are limited, and this is something that a number of us are very involved in advocacy to try to improve the situation of that. But it's a real problem. Funding, reimbursement, access are huge problems. So we want to partner with all of you to try to raise voices about the importance of pulmonary rehab, as Phyllis so brilliantly articulated.
And I wanted to add something that that may be interesting to those of you in the research side. I have, as a burn pit veteran, not only do I have early stage COPD, but I have environmental asthma as well. So if you are not aware of the burn pit registry and the PACT Act, it's a legislative act that is already passed and funded and whatnot. It is a funding source from the federal government. You may be able to take part of, I'm not sure. It is a mandated spending, and so you may want to consider that as a funding source if you're looking for the grant process side. But as somebody like myself who is a very unique set of issues coming from the environmental asthma piece as well as the COPD side, I'd be very interested in the study of both of those things and how does the medication that I'm being prescribed, how do those things work together? And is that doing me a benefit? Is it not doing me a benefit? Because after hearing these things, I'm a little bit now more concerned that some things are working, some things may be working against each other. So consider looking into the PACT Act within your organization, your nonprofit, your NGO, your organization, whatnot, and see if you are able to tap into that funding source if you're looking for grant funding, and consider working with veterans like myself and burn pit veterans. That may be something that you can look into because we definitely have two sides of us that are COPD and also environmental asthma as well.
All right, so I know I have one here, and I think I might have had one in the back there, and then I want to let everybody decompress for a second.
My name's Kenneth. Thank you for your support, doctors, and your knowledge. My question is, can someone's weight, say hypothetically you've gained 10, 20 pounds within the last 6 months, can that affect your COPD, your weight gain?
I would say in general, yes, to the extent that it is an added load that your body and your respiratory muscles are carrying. Weight management, together with, physical activity is, can be of help in to some degree mitigating some responses, but certainly wouldn't blame all of the shortness of breath on weight gain. That's a matter of degree, of course.
And Carolyn, the other problem with weight gain is that it encourages other metabolic problems, isn't it? You can start getting type 2, and these will all they'll make you get exacerbations more frequently or longer, more susceptible to infection. So there are the associated issues of weight gain, which are quite important in chronic lung disease.
Cardiovascular included, hypertension, diastolic dysfunction, other things, sleep apnea, things like that.
How available is that therapy in our area?
So the question was, how available is that in this area? And I would probably refer, I know there's some posters out here that are talking about folks in being able to speak with somebody from Temple to set up a consultation with that, and I would defer to them on that.
There are wonderful pulmonary rehabilitation programs in this area. I just want to call out that livebetter.org website that was developed through the American Thoracic Society in collaboration with the Gawlicki Foundation, who was a grateful patient of Dr. Richard Zuwalick's up in Hartford, Connecticut. And that website has a listing of pulmonary rehabilitation programs in different areas in the country.
One more in the corner there.
Mike, if someone watching online would like to know where to get a COPD action plan that Caroline spoke so well about, where would that person go?
I'm hearing that some people can't hear the questions online. So the question from the audience was, where does somebody go to get one of those My COPD action plans? The short answer is to copdfoundation.org. Click on, I believe, the Learn More tab. You get access to the full downloads library, which also includes the action plan that you can download for your own benefit. So thank you. With that, we'll adjourn for a little while here and let everybody again kind of process, and we'll see you back here in at 1:40. All right, everybody, thank you for sticking around. A couple of housekeeping things as we start getting into the second session here. First of all, I know we had kind of an abbreviated break there, but I do want to emphasize how important our exhibitors and sponsors are to these kinds of events. We're really excited that we had the kind of support that we did, and as mentioned by a couple of our panelists, we really want to develop that advocacy and educational support, and of course we rely on them for events like this and everything else. So please, during the course of the afternoon here, especially as we get into some of the sessions, please make sure that you are checking them out. For those of you who are online, a couple of quick things. I'm told that we are not able to provide the actual all of the slides. However, there is a feature on the webinar where you can save the slide as it's being presented. And then also I should point out that the session will be available as a recording through the COPD Foundation at some time in the near future, and we'll certainly reach out to everybody when that becomes available. Finally, those of you who have submitted questions into the chat feature, we will be replying to you as much as we can via email as follow-up. So if we don't get to your question live today, I apologize. We're getting a lot of really good questions on here, and we're just trying to get what we can on here. So I appreciate your patience, and again, be looking for those answers. So, all of that said, without further ado, I want to jump right back into this. It is a distinct pleasure to introduce a good friend of mine, Mr. John Linnell, who is one of our patient advisors on our Oxygen 360 program with the World Oxygen Day that just happened on October 2nd. And then also Dr. Barry Make. These two gentlemen will be having, as it was described to me, a fireside chat coming up here about oxygen equipment with some non-invasive ventilation. So with that, John.
We just have to say it's a fireside chat without the oxygen.
Yeah, fire and oxygen don't mix. Barry wanted me to start by briefly telling my journey and my story on how I was diagnosed and how I came to be on oxygen, because it's not just an instantaneous thing. I was only 49, and I was having just a routine well check with my primary care physician, and I said to him, "You know, Doc,
it really sucks getting old. And he looked at me and said, wait a minute, we need to talk. 49 isn't old. I know you're a smoker. And from what you've told me, why do you say that? And I said, it's taken me a long time to get up in the morning. Yeah, I get tired more quickly. I feel like the old Geritol ads. He said, let's pull an x-ray, and he did. And he said, I can't diagnose COPD with an x-ray, but from what I see and what you've told me, I'd like you to see a pulmonologist. And although this may not have directly to do with oxygen, that's why there are probably 14 million Americans running around with COPD that don't even know they have it. If I hadn't said to my doctor, it sucks getting old, I don't know when I would have been diagnosed. But anyway, I saw the pulmonologist, was quickly put on an inhaler, told to quit smoking, and sent on my way. A few years later, I was still tired. Another inhaler was added, but they did an overnight oximetry sleep study. Not one where you go in and they glue things onto your head, and I mean, I've had those, they're terrible. I simply slept with a recording oximeter, and my blood oxygen level had decreased to the point where I was put on nocturnal oxygen, which helped my sleep immensely. I still sleep with 2 liters of oxygen, and it makes a huge difference. It's different than a CPAP. My wife does not have COPD, but she has sleep apnea. I don't have sleep apnea, but I need nocturnal oxygen. So we'll move on a few years, and by this time I had moved from the Phoenix area to Minnesota, and I was fortunate enough to be near the Mayo Clinic, where my pulmonologist wanted me to do some more testing, and I had a walk test, and it was determined that I had reached the point where I needed oxygen during the daytime during exertion. And it was very interesting when he prescribed the portable oxygen concentrator, which we'll talk about later when we talk about types of oxygen delivery, different modalities. And it was very clever the way he wrote the prescription. He wrote it to the DME, the Durable Medical Equipment Supplier, a portable oxygen concentrator that will keep John's blood oxygen level higher than 92. Yes, 88 is the standard for insurance and Medicare, but those pulse oximeters have a plus minus of 3. And so I wasn't locked into a 5-year contract with a specific portable concentrator that may not meet my needs in a year or two. So that was the caveat in there that gave me the ability to say this is no longer keeping up with my needs. So, Barry, what do you want me to talk about now, or what do you have to add?
John, I'm coming to this discussion from 2 perspectives. My first perspective is what you all want to ask John. So I will try to represent you, but I am going to do a terrible job at that because I don't know your questions. But the reason we're making this a discussion and a roundtable is because we want to answer the questions that you might have. But the other perspective I'm coming at it from is a physician, but I have 2 different aspects as a physician. Yes, I'm a pulmonologist, but in addition, my family, my friends have gone through discussions with their physicians and not received all the information that they need. And if one thing you heard today consistently so far is you need to advocate for yourselves and what you want to know. That is the most important message we can give you. Don't be afraid to ask questions and challenge. And if you can't challenge your doctor, I would say find another doctor. So my favorite book yet to be written, and the book I'm working on sometime when I fully retire, maybe never, is Talking with Patients. The subtitle is, What Do We Know of Sid Vicious? Do you know Sid Vicious? I didn't know Sid Vicious. So I was sitting with a friend of mine and his wife, and my friend's name was Sid, and his wife said something about Sid Vicious. I said, "Are you calling your husband vicious?" She said, "No, dummy, that's a medical group." I said, "What do I know?" So I don't even talk the same language as my friends. So certainly you don't talk the same language as your physicians, but I would reword that. Your physicians don't talk the same language that you do. So John, there's several things you said, and I want to ask you, as somebody in the audience I think would ask, well, why oxygen? What led your physicians, what did you say to your physicians that made them think, or you think, you needed oxygen?
I'll answer that, but first I want to address what you said about patients and physicians speaking different languages. I talk to a lot of groups. Sometimes I talk to patients, as I am now, and sometimes I talk to physicians. And the patients tell me, my doctor doesn't really answer my questions, and when he does, I don't really understand him, and I don't have the time I need. And the physicians tell me, gosh, I'm just so tired of telling my patients to do this or to do that over and over, and they don't do it. There's a huge disconnect. Patients and physicians need to be what I call partners in care. And we can do this by simply tell your physician the next time you're there, if you feel that way, Doc, I want to be a partner in care with you because I know that what I do is very important to my quality of life and the way you're treating me. I guarantee you their jaw will drop and they'll spend the extra time. But now on to how I was given oxygen. I was still tired, and I had a pulmonary function test, and my FEV1 had decreased to the point where he felt I should have an oxygen walk test. And I desaturated. You're walking, and they put an oximeter either on your earlobe or on your fingertip, and it's monitored. And it was simply proven that my pulse ox was dropping. Now, it's important to understand, no matter what type of oxygen you're using, that just being short of breath does not mean that you need oxygen. If you are out of breath and your pulse oximeter says 93 or 94, the first thing I would do, just for safety's sake, is check the batteries. But there are other reasons you can be short of breath. Maybe you're just out of shape and you need pulmonary rehabilitation. We heard an excellent presentation earlier about that, and it's just a wonderful, wonderful thing to do because it does increase your quality of life. But if your pulse oxygen level is low, too low, and I'll let you discuss that with your physician, what he feels it should be, then you need to use oxygen. And something else that I think is very, very important to discuss with your physician, because when they write the prescription, it's going to say X number of liters at sleep, X number of liters for this or that. Discuss with your physician permission and the ability to what Dr. Tom Petty called titrate to saturate. In other words, ask permission that if you're, say, walking down the street at a brisk pace, walking your dog, and your oxygen level is dropping down, I'm making up numbers, say to 85, and you're using the 3 liters that you were told to use, hopefully your physician will give you permission to turn it up to 4 so you can titrate it up to get the correct saturation. Again, I'm not telling you to do that. You have to have that conversation with your physician. But for example, I need up to 4 when I'm when I'm exerting myself, like walking at a fast pace on a treadmill. When I'm sitting down, I hardly need any. If I'm using a tank, I can use what's called a bonsai valve, which allows me the flexibility to be on pulse, because sometimes I'll only need a low setting of 1.5 on pulse. But then if I get up and have to go and check the mail or walk around or exert myself, I'll turn it to continuous. But again, every one of us is different. But the benefits of oxygen are tremendous. And I'll let Dr. Make tell me if I'm correct or not on this. But by not using your oxygen as prescribed, you're only hurting yourself. And I think, and again, I'll defer to the physician on our panel, But one of the comorbidities of not using your oxygen could be developing pulmonary arterial hypertension, which there's no cure for. We already have COPD, which there's no cure for. Why would we want two conditions that there's no cure for? So, Dr. Make, is that somewhat accurate, or am I completely out of the ballpark?
Yeah,
and
let me
wrong?
step back a little bit and say, why would you want to use oxygen? What are your symptoms that you're trying to improve? You know, as physicians, not just for COPD, but for cardiac disease, for example, we use things to prevent your symptoms you're having now, and we're trying to be proactive and prevent things in the future. Many of you may be on a statin for preventing heart disease. That's prevention, but the statin's not doing anything positively for you now. You may be on a diuretic because without it you developed edema and be more short of breath if you had heart disease. So there's similar things with oxygen. I'm going to draw across other diseases because you need to think about all these diseases, all these chronic diseases as being having very similar issues in terms of treating you now for what your problems are and preventing things in the future. So originally, the nocturnal oxygen therapy trial, John mentioned Dr. Petty, who was one of my mentors in Denver, a mentor to all of us, one of the grandfathers of COPD, grandparents, one of the grandparents of COPD, and he did the nocturnal oxygen therapy study, which was published in 1980. Because of that study, the main reason oxygen is approved by Medicare is to prevent mortality, improve survival. So, is improving survival important to you? Well, it may be sometimes, but maybe not. Some patients say to me, no, I'm more concerned about how I feel now rather than preventing things in the future. Or maybe the most important thing for you is to see your next granddaughter being born because your daughter is pregnant now and going to deliver any day or next month. So you need to think about what your goals are. I always challenge my patients to tell me what their problems are, what they want to do more in life. So if you want to improve survival, John, did your doctors talk to you about improving your survival?
Yeah, I mean, I don't know if he used the word survival or mortality, but he said it'll definitely improve your quality of life. You'll have a more fulfilling life. And, we decided immediately at the Mayo Clinic that working together and discussing it together was the best thing to do.
Okay. Let me finish the survival or living longer. So why would you use oxygen? In what case would oxygen be helpful to allow you to live longer? If your oxygen saturation, when you're sitting here like John and I are, put an oximeter in your finger and it's 89%, 88% or less, 88% or less, using oxygen full time, we'll discuss what full time is, improves your survival. So when you go in your doctor's office, does your doctor have an oximeter and put it on you? Most of the time they do, even if it's not a pulmonary doctor these days, right? Because it measures your heart rate too, and that helps the medical assistant put that information in your record. So if your oxygen saturation is 88% or less, sitting at rest consistently, this is not after an acute episode of exacerbation that we talked about before. If your oxygen saturation is less than 88%, using oxygen, quote, full-time, closer to 24 hours a day at rest and sleep, it improves your survival. That doesn't say anything about shortness of breath. That was just survival I talked about. Okay, so let's talk about the next level here. If you are short of breath, as John mentioned, as Dr. Rochester had a great slide on, there are multiple reasons you can be short of breath. Low oxygen is only one of them. So you need to make sure that discussing in terms of improving your shortness of breath talks about all the other reasons, and your doctor looks for heart problems and muscle problems as well, and anemia, not just your lung disease and your oxygen saturation, because that may or may not be the reason you're short of breath. Really, really the most important thing you can think about. So there also is a controversy. Now, I say it's a controversy because many of your physicians will say one thing, and you go to another physician, they'll say another thing. So suppose your oxygen saturation when you're sitting here is above 88%, but you get short of breath when you're walking. Well, so what does that mean about your oxygen? Well, if your oxygen goes down when you're walking, does shortness of breath always helped by oxygen if your oxygen goes down when you're walking? No, it doesn't. In some studies where they've used person walks around, their oxygen saturation drops, they give them oxygen or don't give them oxygen. In some studies, oxygen does not improve your ability to walk around. In other studies, it does improve your ability to walk around. So there's kind of conflicting studies. Then there was a long-term study that some of the people who are on the dais here, including Dr. Chronic and I, participated in, called the long-term oxygen therapy trial. It looked at people who only desaturated when they walked and gave them oxygen or not. Their survival was not any better. Their quality of life was not necessarily better either. So it depends on you as an individual, how low your oxygen saturation drops, what other conditions might be causing your shortness of breath, as to whether using oxygen only when you're walking around, if your saturation is okay when you're sitting, whether oxygen will improve you. So that's a discussion you need to have with your physician.
With the last couple of minutes we have, I know we started a couple minutes late, but I was wondering if the two of you would talk a little bit about the equipment that's used, particularly as you're walking around, just to give us a little bit of a better sense of how to work with that.
Yeah, I would love to talk about that. I work with Mike on COPD, Oxygen 360 with the foundation. And most of the time when we're walking around, many of us don't drag a tank. We especially when you travel, you use a portable oxygen concentrator. Very few of them, in fact, none of the lightweight ones are continuous flow, they're pulse. And many people think that the setting is a liter flow. It's not. There's one very famous brand that has a setting that goes up to 6. The amount of oxygen it actually produces is 1.36 liters a minute, less than 1.5. Now, granted, it only dispenses the oxygen in what's called a bolus, that puff, when you inhale, so you're not really wasting some of that oxygen, but it's definitely not liters per minute. Yet many people wind up buying them out of pocket, and they wind up with something that doesn't satisfy their needs, or if it does, maybe for just a year or two. So I always say try before you buy. It's very important. That the heavier ones that, in fact, mine is, they were so kind to let me use a tank while I'm here in this room, but my portable concentrator is on a cart, and it's in the back of the room plugged in. If you want to take a look at it, and it goes up to 2 liters continuous, which I need when when I'm traveling. Try before you buy. Be aware of what your concentrator is actually delivering. We're also working on, can I touch on liquid just briefly?
Very.
Liquid oxygen used to be available, and liquid oxygen was such a blessing because it's lighter weight, it lasts longer, but due to a competitive bidding, the DMEs weren't making any money. But they're a company, they deserve to make a profit. I wouldn't sell anything if I was losing money. So liquid has pretty much gone away. There are very few people in America still using it. I was fortunate enough to be invited to speak at European Respiratory Society in Milan, Italy, a few months back, and the oxygen supplied to me there was liquid. Oh, I was spoiled. I was there for a week, and it was just, I thought, oh my goodness. Liquid is the standard modality of choice in Europe. Everybody uses it, but not here. We need to advocate for ourselves and for the entire respiratory disease community that use oxygen and get that changed. So write to your congressman.
So the message here is embodied in the slides. When you use oxygen, talk to your prescriber about the different methods available and what is best for you as an individual. And everybody wants to system that's the lightest and easiest to carry around, but it may not meet your needs, and make sure that it does, as John said, before you buy it. So I want to end this session with two more things we were supposed to talk about. In terms of non-pharmacologic therapy, there are two other things you may hear about, and I don't want to go into detail because you don't have any time. One is not the regular oxygen we're talking about, but high flow. Much more oxygen coming out of the system, much higher flow rates. Much more oxygen. It's called high flow oxygen. It's a different kind of setup than the ones you have in this room. A little bit different kind of nasal cannula. It may have benefits in keeping your oxygen better, maybe helping your work of breathing, maybe reducing exacerbations. High flow oxygen, look for it in the future. The next is something that's here now, and I think used to be used too much and may or may not be used too much in certain places for COPD. It's called non-invasive ventilation. John mentioned his wife uses a CPAP. It's a mask that goes over your nose or nose and mouth, and rather than you breathing in, it helps push the air in. When used the right way, and this is very difficult, your physicians need to understand how to do it, Dr. Kreiner being one of the experts in this country in terms of how to do it, make sure that they understand how to do it to achieve the benefits of improving your survival. And again, maybe reducing exacerbations. A system you use only at night to push the air in, not just the oxygen, but the oxygen and air, rest your respiratory muscles, lowers your carbon dioxide. That's only beneficial for people with high carbon dioxide levels. The only way to know that is to get stuck in your artery and do an arterial blood gas. So those are two other things to think about, but you know, there are much fewer people benefit from them than the oxygen that we talked about. Thanks, John.
All right, well, thank you both very much. Really enjoyed that, and hopefully everybody is a little bit more informed about oxygen. A lot of stuff on the horizon out there with reform to improve this access and all that, so keep an eye on that. Now, for our last session of this grouping, it is certainly an honor to introduce a couple of folks who are right here from the Philadelphia area. For the patient advocates, we have, should have brought my readers. Mr. Ronnie Neal and Ms. Bernice Shaw, and somebody who probably needs no introduction at all, Dr. Jerry Kreiner from Temple University.
Thanks, Mike. Well, there's a reason why we're last. So you've done everything that everyone's told you over the last couple hours to do. Use your medication, do rehabilitation, use supplemental oxygen, but you still don't reach your goal of improving your quality of life or alleviating your symptoms of dyspnea. So what else can be done? So if you don't remember anything else from this session, there's two things to remember. Emphasize what the other speaker said, ask questions. Because if someone says there's nothing else they can do for you, there's always something that can be done to improve your quality of life. Never give up hope. Second thing is, if you have the opportunity to participate in a clinical trial, do it. It may not help yourself at that minute, it will help you in the future, and it will help other people that are afflicted with your disease. And what I'm going to go over for you for the next 20 minutes with my partners, Bernice and Ronnie, is talking to you about things that they did as participating in novel therapies and clinical trials that led to improved therapies for thousands of patients who suffer from COPD. These are my disclosures, which are mainly research and consulting work to develop research projects. So let's first start with Ronnie. Ronnie and I have known each other for 13 years. Ronnie, want to tell the group about yourself and your symptoms? You have to press the button, Ron.
Yes,
Good.
My name is Ronnie Neal. I've been suffering with the COPD close to 20 years. And when I first heard of it, I didn't even know what it was. And I asked some doctors, and I was just going there to take my medicine. And I eventually came to Temple, and they treated COPD as a more aggressive way. And there's some things I didn't hear about before I came to Temple. And even before I even go further into that conversation, in the past 4 months, I was presented this beautiful gift. I had a lung transplant at Temple. And 4 months ago, I couldn't walk 10 feet without being out of breath. And I'm just so blessed to stand here and able to do this and tell you this. But the COB community, the medicine that they're doing is just so amazing what they're writing right now. And the main thing I can say is, like when you go to your doctor's appointment, ask a question. If there's something's wrong with you one day, your ankle's swollen, maybe jot it down, because one thing I started doing once I came to Temple was to be proactive in my life, because no one can monitor your life better than you can. And so just make a little note, write it down, because there's so many times that we might have went to the doctors and forgot to ask that question, and you get home and say, I didn't ask my doctor this question. So write it down, take it there, you know, and it's, these are just some of the basic, simple things. And when we have COPD, a lot of us can't eat the same way. We're supposed to eat like 4 or 5 meals because we can't eat the whole meal at the same time, you know. And one of my biggest things is always just try to stay active, you know. And a lot of us with the COPD, we can't do everything that we want to, but some days we can walk a little bit. Get your loved one, maybe walk a half a block or something like that, with the consent of a physical therapist of your doctor. But doing these things is a good thing when you have COPD. And the benefits are not going to pay off overnight, but in the long run it will. And I wish all of you nothing but the best, and that's part of my story.
Thanks, Ron. And Bernice?
Sure. Hi. Thank you. I started smoking when I was 13. I came from a smoking family. Both of my parents smoked. My grandfather smoked. My brother smoked. My aunt smoked. And I smoked for, I think, 30 years. I quit in October of 1993. So this year, on my birthday, was 30 years that I quit smoking. We were on a short vacation, my husband and I, about 20 years ago to San Miguel Allende, which is in the mountains, has a higher elevation, and I realized there was something wrong. I couldn't walk up the hills, I was out of breath, and when I came back, I said, I have to see somebody. So I went to a pulmonologist for the first time, and I took various breathing tests, and when the results came back, they said I had emphysema, and I was in my 50s at the time, and he said I had the lungs of a 75-year-old woman. Now I'm 75, I don't know what age my lungs are. Yeah. So he said I should get on a list for a lung transplant. I did not get on the list, but I started taking various inhalers like Advair and Spiriva and others, and they kept switching medications, so now I'm currently using Trelegy, Daliresp, and I use Ventolin inhaler when I need it. We were again vacationing in March of 2020, and then COVID started to rage, and we came back home, and I was very careful about not getting COVID. I didn't go to the gym, I didn't exercise, so my breathing got much worse. So my pulmonologist in New Jersey, I live in New Jersey, said, well, maybe you should take more breathing tests. So the tests came back and my numbers were really bad. And there wasn't much else to do. There was no new medicine, and at that time I had, about a year before, there was an article about the BLVR procedure in AARP magazine. So I mentioned that to my pulmonologist, and he said, oh yeah, maybe, you would be a good candidate for it. So I contacted Temple, and I started to do the preliminary tests to see if I was a good candidate for the procedure, and I was, which was terrific. I forgot to say that my poor breathing really affected my daily life. Going grocery shopping, doing laundry, even taking a shower was difficult. I would come out of the shower and I just couldn't breathe, and it was really terrible. I had the procedure, the BLVR, in September of 2021, 2 years ago, And I was in the hospital for 4 days after. Everything seemed to progress well. I was on oxygen for first 10 days, and then I met with Dr. Kreiner, and he said I didn't need it anymore. And I did start physical therapy, rehab therapy, which was really invaluable. And one thing that I got out of this panel so far is that I really have to keep up with the exercise. I think that's so important. So I'm not on oxygen now. I'm going to the gym, and I still have emphysema, but my life is so much more improved. And I wanted to visit, we like to travel a lot, so I wanted to visit Machu Picchu, but I think because of the altitude, Dr. Kreiner said he didn't think I was such a good candidate. So
New Jersey's better.
He said, what about Paris? So he said he thought I'd be able to walk a mile in Paris, which I did. I was there in June. So thank you, Dr. Kreiner.
No, thank you. So Ronnie and Bernice, they really amplify a lot of things, but they show, I think, regardless of gender, regardless of race, regardless of age, COPD doesn't care. It afflicts all of us. And how to approach it, though, depends on characterization of what the primary problem is. This is Ronnie's lung function. You can see over a 10-year period of time, that over a 10-year period of time before he had his first procedure, he ended up decreasing his lung function by 2/3. His lung function was 17% of predicted. And I think, as some of you in the room know, it's bad news when they have to take 2 x-rays because they can't fit the size of your lungs on 1 x-ray because they're so large. So hyperinflation is a major problem for Ronnie. Same thing with Bernice. This is her x-ray to the right that also shows that her lungs were very large, causing and contributing significantly to shortness of breath. So if we look at people who are short of breath, despite all the therapies that they're on, the implication of hyperinflation, that's what the medical term is for lungs that are too large, can cause many problems for how the lung, how the heart, how the chest wall, how the breathing muscles operate, that contributes to shortness of breath at rest, and even more so with exertion. If you look at patients and surveys with patients with COPD, 50% of the time, the thing that they complain the most, the symptom, is being short of breath. Despite everything that the doctor gives them, they're still short of breath, and it's their most important complaint that isn't really rectified by anything that's given to them. Well, there's reasons for that. Shortness of breath and hyperinflation, 2 big lungs, can be due to very varied factors. The slide on the patient on the left from a resected piece of lung shows that the airway is decreased in size, but it's decreased in size because the emphysema around it isn't providing the radial stretch to keep the airway open. That's different from the patient on the right, where the airway is occluded because of mucus or hyperplasia, increased cells in the lining of the airway, and inflammation. Both of these patients can have big lungs, but the cause of it is very varied. And that gives us different targets to be able to use to treat a patient despite just oxygen or rehabilitation or medical therapy alone. So this is back to Ronnie again. Characterizations needed by pulmonary function tests to see how obstructed you are, how big your lungs are. And one of the major benefits that we have now is being able to characterize patients by using CAT scans with high fidelity to be able to look at the structure of the lung and determine if there's a feature of the lung that allows us to treat them. Same thing with Bernice, where she had the same physiologic characterization to show that she was obstructed, her lungs were big, but there was a region of her lung that was most diseased, the top left, that we could target for treatment. So how do we know? I told you how bad hyperinflation is. How do we know that if you have emphysema as a cause of hyperinflation, that we can, quote, deflate you with an intervention, in this case surgery, and that provides a benefit? Well, that's based on the National Emphysema Treatment Trial, or NET, that was a study carried out by CMS or Medicare with the signs driven by the NHLBI from 1996 to 2003. And after $175 million were spent over 7 years of the study and 1,218 patients, the results come to one slide. That if you're a patient that has lung reduction in addition to optimal medical therapy, you have an improvement 15% overall in survival with marked improvement in quality of life and exercise performance. But we know with characterization, with the way the X-ray shows the distribution of emphysema and how air-trapped you are with exercise, that we can profile the benefits for patients to a greater degree. If you look at the bottom left of the slide, to the left, the green, people that are very ventilatory limited during exercise and basically have upper lobe predominant emphysema can have a significant survival advantage compared to just an exercise performance by itself. So we know that this therapy can help patients live a longer life and a better life, but we also know that like other therapies like this, it carries morbidity and mortality. There's about a 4.3% mortality at 90 days in the high benefit group and about a 50% cardiopulmonary morbidity with the things that are listed there, pneumonia or exacerbation. So in about 1998, we started to look for other therapies, less invasive, that could accomplish the same technique. One is putting endobronchial valves that Ronnie and Bernice had, trying to do targeted lobe atelectasis or putting coils to grab and shrink the lung, or to use therapies like flowables or steam that could take an area of emphysema and scar it, shrink it, try to do the same thing that surgery does or a valve, but try to do that in a way with using different techniques. And the third is just put anomalous bypass tracts into the lung. Well, there's 2 studies done in the United States from 2013, 2014 through 2018 using 2 different forms of endobronchial valves with studies that were designed looking at patients with big lungs and looking at them over a period of 6 months to 1 year, looking at how that changed their lung function overall. And these 2 studies showed comparable results. This is the first study, the Liberate trial, that showed in patients that are about 68 years of age that had lung function 28% of predicted with the FEV1, with large lungs, with lobes that were destroyed by emphysema by about 70%, that could only walk 300 feet, with a third of them on supplemental oxygen, and all of them on optimal medical therapy, including inhalers with triple therapy and pulmonary rehabilitation. After this therapy with the endobronchial valve, they ended up 45%, 47% of the group had a 15% or greater improvement in FEV1 at 1 year. 1 year, 100 mLs in people with irreversible airflow obstruction due to emphysema on already optimal therapy. And as you can see, they had significant improvements in 6-minute walk distance compared to control group and significant improvements in quality of life. They found that if you looked at the patients overall and looked at the minimal important clinical differences, that 50 to 60% of patients had better lung function, quality of life, were less short of breath, and could walk further. And that was tied to a mechanism which was decreasing the target lobe with emphysema. Similar results were shown with the other device, showing that patients had significant improvement of lung function, quality of life, and less shortness of breath. This is the results of Ronnie, as you can see. His lung function was about 17% of predicted. Ronnie had a tripling of lung function with treating his left upper lobe. Bernice had similar results. Also, her target was the left upper lobe also, showing a significant improvement in lung function tied to a decrease in lung volume overall. But these patients who have the phenotype for this is only about a third of the patients. 70% of patients don't have the right anatomy to have a closed lobe that could really respond to an endobronchial valve. And these other patients with these other groups, the 70%, the broader population that exists who are hyperinflated, that's where we need the research to be able to treat those patients comparably with good success that we see with the valves. Currently, we only have lung volume reduction surgery. And if you look, since it was approved by Medicare in 2004, Only 160 to 180 Medicare patients get lung volume reduction surgery throughout the United States because of lack of awareness of the benefits, difficulty with characterization at local sites, or the perceived negative outcomes. You have to have a specialized center that can really perform this safely for individual patients. So in someone like Ronnie, who had good success, he had good success for 5 years, but then Ronnie started to complain of increased shortness of breath. And what is the next therapy that's available to patients like that? Well, it's lung transplant you can consider and select patients who meet those needs based on these kind of outlines of when to refer and when someone should be optimally listed. And this is Ronnie's outcome. Ronnie was transplanted 10 months ago, Ron?
Like 4 months,
4 months. Time goes by. 4 months ago.
4.5,
But you
five.
can see
Yeah.
remarkable improvement in Ronnie's outcome. With a single lung transplant done on the other side, and Ronnie's improved his lung function by about 300 to 350% greater than where he was before. This gets back to the phenotype again of characterizing what else can we do for patients like this. So let's focus on the right side of this slide. There are 3 large prospective randomized trials looking at experimental therapies trying to open up the airways, denervation shown to the left, and trying to tackle mucus hypersecretion to the right with using rheoplasty on the top or metered-dose nitrogen cryospray. 2 of those 3 studies are completed. The third will be completed in 6 months. So there might be 3 potential new therapies if these meet the metrics of being approved by the FDA to improve a patient's outcome. So that's why we never give up. We keep looking for targets and basically trying to improve the plight of patients overall. So if we look at now, compared to 10 years ago, what does that mean with a patient with COPD with a mixture of emphysema and airways disease? We have these potential treatments now with endobronchial valves. We have the potential with using these other forms of therapy for patients that can't get an endobronchial valve. We have the potential treatment for chronic bronchitis or airways disease in the trials that are ongoing, or we can use denervation to help to treat with exacerbations and slightly improve lung function and quality of life. So there's other therapies that are available for us, so never give up hope. Ask questions and participate in a clinical trial if you're able to. Thank you.
All right, with that, we open it up to first questions from the room for any of our panelists from the second session here. Yes, ma'am.
You recommend talking with your doctor. Doctors commit 7-10 minutes per patient, and then they're walking out the door. They're easing their way out, they're pretending to listen, but they're on to the next patient. How do we do something to examine how we can speak with the doctors for a better period of time, how we can get better information and better communication?
My biggest suggestion is when you go see your doctor, I don't know if you go by yourself or with someone else, just please have something written down that you want to ask your doctor and make notes from there. Because if you do that, you get more information. There's times I used to go there with a list of things I remember. But you want to have some type of list because we go there because we're sick. And so if you have a list there, take your time. The doctor will take his time. All right? I don't know your doctor. I know my doctor. I don't know your doctor, so I apologize.
I always come in with a list.
Yeah, yes.
When I have a problem. But the doctors are really in a rush to get through your list, and sometimes they won't even do it.
I never experienced that, but again, you must demand that they listen to you.
Two answers. And of
Yeah,
course,
because
the first
this is your health, okay?
2 answers. And first, organization, absolutely. The second is that today, physicians can bill based on the time they spend with you. So I think it's important if you think you need more time before the visit, schedule more time, tell the doctor what you want to do and the fact you have all these questions and you want to spend more time. I truthfully, though, don't know how often that helps, but it should, because again, doctors base build on time. Jerry, do you have another answer for that?
No, I kind of can see your point. I mean, I think there's people that do medicine because they love medicine, they love to interact with patients, they try to help patients. Then there's others who don't maybe have that inclination. But there's a lot of doctors. So if you talk to other people, and I think the COPD Foundation with, the 360, find somebody who basically has an interest in you as a patient and who will do their darnest to try to help you. So it might take a little bit of persistence on a patient's part to do that, but all doctors won't spend 10 minutes with you. Try to find one that will be attentive to you.
Any other questions? All right. Well, we have certainly had an outstanding group of panelists today. So first, I would like to thank and acknowledge all of our clinical experts and certainly our true subject matter experts, the people who are out there living with COPD. So let's get a round of applause for everybody who's on the panel today. If you'll indulge me for a moment, I saw in my role as a respiratory therapist and advocate with the foundation, I saw a couple of common threads today that kind of went through each of the sessions. It's really critical to have good, open, clear, closed loop communication with your clinician. It's really important to be your own self-advocate and to develop your support system if able. And most importantly, the one thing that I hope you all leave here today with is that you are not alone on this journey. You have a lot of people in this room, both with COPD and on the clinical side of things, that are here to support you, that are here to cheerlead for you, and to help you be that advocate. So again, I hope that's a big takeaway for everybody today. I would also invite everybody to make sure that you check out our exhibit hall. Again, we can't do this without them. We have another half hour or so of a break here before we get into our, as Dr. Kreiner mentioned, the COPD 360 social patient reception, where we're going to be covering a lot of questions that we get through that social site and that social support network, featuring from the foundation, my fellow respiratory therapist, Stephanie Williams, and Dr. David Menino. So thank you very much for all of you who attended in person today, attended online, and for supporting this initiative. Can't thank you enough. So have a great afternoon.